So we are going to start the next session. So this session is an industry symposium by Sanofi. So to chair this session, I would like to invite Dr. Imtiaz Hassan. He is Medical Director of Diabetic Institute of Pakistan. He was a member of editorial board of Monthly Sugar and exclusive newspaper for diabetic patients. His research work is published in different national and international peer-reviewed journals. Welcome, sir. Our second chairperson of this session is again my teacher in fellowship program and my mentor, Dr. Mohammad Kamar Masood. He is Associate Professor Endocrinology at Aga Khan University. He is Diplomate American Board of Internal Medicine and Diplomate American Board of Endocrinology and recipient of Naeemul Haq Excellence Award by Pakistan Endocrine Society. Welcome, sir. So, our topic of this session is treatment simplification in type 2 diabetes, spotlight on basal insulin therapies to manage diabetes. And for this, I will invite Dr. Safdar Naqvi. He is consultant physician and endocrinologist, Imperial College London, Diabetic Center Abu Dhabi. He is trained in diabetes and endocrinology at University College London Hospital, UK. He is former consultant endocrinologist, St. Peter's Hospital, NHS Trust, UK, former medical director, Imperial College London, Diabetic Center, UAE, and consultant endocrinologist, Imperial Healthcare, UK. Can I request you, sir, to come?
Sir, assalamu alaikum everyone, and I hope you can hear me pretty well at the back as well, and I hope it is. So, what I'm going to talk about is, I think, an introduction to basal insulin, but more so the theme of the next 20 or 25 minutes is just going to be simplification of treatment for diabetes, and we're focusing more on type 2 diabetes. And I'll share with you some evidence relates to the basal insulins that are in use, and I'm told that they are more and more used in this country as well. I had a lot of experience with them over the years. So before I start, I think the discovery of insulin in the 1920s, I think, was one of the biggest medical breakthrough. And for a number of years, insulin was the only treatment that was available for patients with diabetes. And it is indeed the only treatment for which we have the most experience to date. So we must keep this in mind, that we have a lot of experience and the treatment is there for a very long time. But I must mention Elliot Jocelyn, because he treated the first few patients with diabetes, but his biggest contribution was introduction of education in diabetes. And I think he should be remembered for that. We must also remember Frederick Sanger, who basically carved out the structure of insulin and won a Nobel Prize for that. I think this topic is very kind of timely in the sense that, we keep talking about the burden of glycemia. The diabetes is kind of roughly hijacked on the cardiorenal side now, and we've forgotten about the glycemic burden and the clinical inertia which continues to haunt all of us. And I think together with those, it's very important that insulin is started in a timely fashion. We all know this is all old data from UKPDS. I mean, the legacy effect and what happens if we control diabetes effectively and early. So it does help. We reduce microvascular outcomes, and if we treat the other risk factors as well, we also reduce macrovascular outcomes. The problem is this: we still have a very conventional approach. A lot of it is related to how we are trained, how our patients perceive the treatment. But what happens is that there is a considerable delay in terms of treatment intensification. So what we are now moving towards is giving combination treatment early and trying and addressing the various kind of pathophysiological defects in diabetes. So using early combinations, for which we have emerging evidence now, and try and get the sugars into target early. This is again back from UK PDS days when I was in training, that if you reduce the sugar effectively, you not only reduce microvascular complications, so it's just a 1% reduction in A1C, reducing the microvascular complications by 37%, but clearly effect on macrovascular disease as well. This, I think, is the most important slide. And by timely and effective reduction in glycemia, you actually give rest to the beta cells. There is less energy pushed to the mitochondria and they start to function better. So you get a better glycemic control. So that's the most important thing. The second is insulin, which has a very important effect in terms of, production of nitric oxide and its antioxidative effects and vasodilatory effects. You basically reduce inflammation and the antioxidant effect. And the third thing which we have seen, and we have plenty of data, is the metabolic memory. So what's the optimum starting point? So what we know now in the glycemic section, as you know, the whole of the guidance is all about cardiorenal metabolic, but we still have a small section on glycemia. And if you look at that, insulin is a very effective treatment, a highly effective treatment. So this is what we have accepted, that if we need to reduce it effectively and early, insulin in patients is a very good option to take. We also have a consensus statement that if you are to start insulin, and if you have the option of longer-acting basal insulin analogs, they are probably the best way to start insulin initiation. And part of that I'll show in the later slides why these basal analogs are better. Some of it is here. I think the two key things here is that these analogs, which are longer acting, have less variability. And because they have less variability, therefore, they cause less hypoglycemia. And if you have less hypoglycemia, there is less weight gain. So more acceptable to patients is once a day, and therefore it improves adherence as well. So this is quite important, really, takeaways from the longer acting basal analogs. So why choose them? Because compared to the first generation insulins like Lantus or Levemir, I mean, if you look at the mechanism of action of glargine U300, it basically has a smaller depot, and insulin is released very slowly from that depot. So you have less insulin, and it releases slowly, and therefore gives a more realistic and long-term suppression of gluconeogenesis. So this has been widely studied. If you look at the addition study, which was U300 compared with glargine 100, it was efficacious in patients with type 2 diabetes, and there was less hypoglycemia. Similarly, the degludec in the BEGIN trials, which again, type 2 diabetes, similar results. And the two have been compared head-to-head in the BRIGHT studies, and they showed kind of equal effect in terms of HbA1c reduction, and their hypoglycemic effect was very comparable as well. The ATOS study was basically a real-world data. So what they did was that you have evidence from randomized control trials, but does it work in the real-world setting, and does it work across different geographies? So it does. So it does exactly what it does in the randomized control trials, that it is efficacious and it causes less weight gain and hypoglycemia in the real-world setting as well. And definitely, patient satisfaction was improved because there was less hypoglycemia and more people were achieving targets. A similar study was the Artemis study, which is again done across different geographies and looked at the real-world evidence, and it again showed that the drug is equally efficacious if you switch to U300 glargine. So if we compare whether the two longer-acting analogs are compatible and comparable, then you look at the InRange study, where it shows that there was similar reduction in A1C, and changes in the insulin dose was not terribly different in both the groups. And there was equal kind of variability ratios for both the insulins. And therefore, not surprisingly, there was less hypoglycemia between the treatment groups. This is just the indirect treatment comparisons, and this is with glargine and the combination insulin Ryzodec. I think it comes with the same name here. And this is in terms of improvements in HbA1c, the dose of insulin that is required, and obviously effects on its weight. So I also understand that more recently we are starting to use the combination analogs a lot, primarily because it reduces the number of injections as well. But if you use a basal insulin, it probably gives you equal effects. And in this study, you will see that there was insignificant difference if you use glargine U300 and Ryzodec. And basically, there was not a great deal of dose difference, so you did not require a lot of basal insulin to get the targets. But what was very helpful, that in the basal insulin group, there was less hypoglycemia and weight gain, which is, again, something quite positive and improves adherence of the patients and satisfaction. So the other thing which I personally like about this insulin a lot is the flexibility, because we all are aware of the insulin stacking effect and the effects on hypoglycemia, and the problem that patients don't take the insulin at the same time every day. And this insulin offers you the flexibility in the sense that you have a 6-hour flexibility window, and you can take it either 3 hours before or after, and there is not a great deal of effect on blood sugars in terms of hypoglycemia. So a longer acting analog, which is quite comparable to the other available long acting analog, quite comparable to the mixture of long acting analog and short acting analog insulin, and also in addition gives the flexibility that, you know, if you are delayed in your dosing, it doesn't really affect much. So the real take-home message is from what I have shown so far, that there is comparable A1C reduction, as I've just shown. What I've also shown that there is reduced variability, and I think that's the key feature of these longer-acting analogs, because the reduced variability results in less hypoglycemia and less weight gain, which is, again, two of the most common kind of issues that patients face and the questions that physicians face is about hypos and weight gain. The administration is very convenient, the flexibility that I have shown, and obviously when we have compared, even head-to-head or compared with previous insulins, is equally efficacious and with a reduced incidence of hypoglycemia. So I move on with the same theme, which is basically simplification of treatment. And I think perhaps simplification will make people more adhere to treatment and basically improve outcomes and reduce the glycemic burden. So these are just various consensus treatments, and they all, I think, saying the same message. And the message is really that, you know, if we can simplify, and particularly in the older age group, it is very helpful. So the guidance in a consensus view is that simplification where possible should be the way forward. So I'm going to talk about, in terms of simplification, a combination, which is basically a combination of long-acting insulin and GLP-1 analog. This is the I-glargine and lixisenatide combination. And this combination has been studied across, you know, the diverse kind of combination populations. It has been studied in those who are insulin naive, in patients who were on oral agents in basal insulin, patients who were on oral agents in GLP-1 analogs with basal bolus insulin, and against premixed insulin. So it's a spectrum of really various clinical combinations of medication. And if we look at the evidence against the premixed insulin, you will see in the Solimix group that the change in A1C and the fasting glucose, it was non-inferior. And similarly, there were greater reduction in the fasting plasma glucose with the combination or the fixed ratio combination. FRC, I always thought it was Fellowship of Royal College. I was just told today is fixed ratio combination. So FRC is fixed ratio combination, which is the combination of GLP-1 analog and glargine. So again, if you look at the change in body weight and all that, there are positive effects with the combination compared with the premixed insulin. So it was superior in body weight and resulted in lower hypoglycemia. If we look at the comparison with a basal bolus regime, where you are comparing BI is basal insulin and rapid-acting insulin is RAI, it's not radioactive iodine. So if you compare with the basal bolus insulin, again, it is non-inferior in terms of change from in A1C, and similarly superior in terms of the benefits on weight. These are the two new kind of studies that were presented in the recently held EASD in Madrid. And this was the SOLI switch trial, which basically looked again at efficacy and safety of switching to this combination from premixed insulins in people who had type 2 diabetes. And the outcomes were that, if you switch from a premixed insulin to this combination, you not only simplify treatment, but you have improved glycemic outcomes and you have benefits in terms of weight loss as well. So evidence from previous studies, which some of them were basically phase 3 studies, and to a newer kind of evidence, all supporting all the way that fixed ratio combination with the GLP-1 analog and insulin is probably a better simplified way of treating patients with diabetes, type 2 diabetes. And this is the last couple of slides, and I requested these slides to be put in because this evidence was also presented, and this looks at actually comparing the fixed dose combination with Ryzodec, which is the insulin Degludec and Aspart combination, and this is in the Chinese population, the SOLID trial. And so the 24-week kind of study, and it was a head-to-head trial. And if you look at the benefits in terms of non-inferiority, in terms of benefits, in terms of weight loss, more patients achieving targets, and lower hypoglycemic events. So if I were to conclude, I would say that, the treatment burden remains a key barrier. I think we need to focus on glycemia as well. We mustn't forget that sugars need to be reduced. We are very focused, as I said earlier, on the cardiorenal side, which is the correct thing to do, but we mustn't forget that the underlying pathophysiology is very much glycemia driven as well. So, and we have plenty of evidence for that as well. So we need to simplify treatment. We need to be more aggressive and try and get the sugar in the normal range, if not in the acceptable range as early as possible, to avoid both micro and macrovascular complications. So what I've tried to show you today, that use of basal insulin, and if we are to use basal insulin, the longer acting analog, as they have reduced variability ratio and less incidence of hypos and weight gain, should be the way forward. If we are to use combinations, then the combinations of a basal insulin and GLP-1 analog is a very simplified way of treating diabetes patients to targets. And I think with that, I will say thank you very much, and I will leave the session to the chair.
Any question from the audience? Please introduce yourself.
Assalamu alaikum. My name is Dr. Muhammad Arshad. I am diabetologist. इंसुलिन ग्लार्जिन हमने स्टार्ट की तो HbA1c रिडक्शन कितना होगा, और आपने अपनी स्लाइड में जिक्र किया है कि स्पेशल पॉपुलेशन का, व्हाट डू यू मीन स्पेशल पॉपुलेशन?
I don't see which special population actually. किस स्लाइड के
20% हम स्पेशल पॉपुलेशन में इंसुलिन इस्तेमाल करते
देखें
हैं।
जो एफिकेसी में देखें, इस एफिकेसी पे आपको बता देता हूँ। जो एफिकेसी है इट इज़ बेसिकली सिमिलर इफ़ यू लुक एट द एडिशन ट्रायल्स, तो उसके अंदर जो एफिकेसी थी कंपेयर टू ग्लार्जिन U100, तो वो नॉन इन्फीरियॉरिटी ट्रायल था, यानी दोनों की जो एफिकेसी है वो एक जैसी थी। The only benefit, as I said, of these basal insulin, special populations अगर आप देखें तो वो हैं जो elderly हैं, जिसको सारी consensus statements दी गई कि जब elderly लोगों में आप यूज़ करें तो you use a longer acting analog because उसके hypoglycemia होने का चांस कम होता है। तो जो ट्रायल्स थे वो नॉन इन्फीरियॉरिटी के थे, तो उसमें ये था कि द एफिकेसी या इन टर्म्स ऑफ A1C रिडक्शंस वो comparable, एक जैसी थी वो U100 और U300 के अंदर। But the benefits of longer acting insulin is basically hypos. And the second thing is that, you know, because you get less hypos, because की variability कम होती है, so you get less weight gain and there is more adherence to the. So the special population is the elderly, if that is the question.
स्पेशल पॉपुलेशन का दूसरा वर्ड्स हम जो मेडिकल वाले यूज़ करते हैं, जैसे हैंडीकैप है, ब्लाइंड है पेशेंट्स, एबनॉर्मल है, क्या उसका भी जिक्र इसके अंदर है 20% में? क्योंकि लॉन्ग एक्टिंग है, आपने कहा कि हाइपोग्लिसीमिया के चांस कम हैं।
देखें, if you're talking about renal patients, so renal patients में you're right, renal patients के अंदर the risk of hypoglycemia is very high, and the reason is there are only two organs in the body that produce glucose. One is liver and the second is kidney. So A, you don't have gluconeogenesis there, and the second is कि insulin की clearance जो है वो effect होती है। So yes, that group as well. So any groups that are vulnerable to hypoglycemia, I think the basal insulins are a better way of giving it because of the sustained release of the monomers. That's really what it is. So special populations are, I think, very much dictated by you in the clinical practice because across the spectrum इतनी studies नहीं की हैं, तो इसलिए उसका जवाब देना on the basis of evidence is going to be difficult. But you are right. If your question is about the populations at risk, the consensus था that was around people who are elderly. But you are right, anyone who is at risk of hypoglycemia for whatever cause, these insulins are better compared to the earlier basal insulins.
Any other question, please?
I have two questions.
Sure.
First question is that in the books it is written about the treatment of type 2 diabetes mellitus guidelines. Start from the drugs. My first question is that can we start insulin right from the diagnosis in type 2 diabetes mellitus because 70 to 80% of the beta cells are exhausted when you develop diabetes. If you start initiate insulin at the beginning of the diagnosis of type 2 diabetes, you give it like for 1 year, 2 years, 3 years, you give rest to the pancreas, and meanwhile you motivate the patient to like have a lifestyle changes like exercise and weight reduction. Meanwhile, you manage his glycemic control with the insulin, and when you have in normal range HbA1c, you stop the insulin and just focus the patient on lifestyle changes. Is it a better approach or not? And my second question is that if patient has a baseline creatinine level 1, if it becomes 2 suddenly over a couple of hours or 1 day, 50% of the function of kidney is lost if creatinine becomes 2. And if creatinine becomes 5 and it jumps to 10, I think it does not does not mean anything because you already have lost most of the function of the kidney. Regarding this basic concept, my question is that if a patient is diagnosed with diabetes mellitus, like in our country, I have seen many patients in practice, when they come, their HbA1c is even 14 or 15. In first slide, you showed that if you have 1% reduction of HbA1c, there are so benefits on amputation, this. My question is that if a patient has HbA1c of 14 at the time of diagnosis and you reduce it to 13, can you have the same benefits for that patient?
Okay. So thank you for both questions. So shall I reply in Urdu or English? So English, okay. So I think regarding your question about when people present with very high sugars, and if you give them insulin and normalize their sugars, is this the best way forward? Because then you can tackle diabetes better with lifestyle changes and medication. So it has been looked, and it is definitely a very reasonable way of doing it. So what happens is when, as you said it yourself as well, when the sugars are very high, you have a very high energy push on the mitochondria. So your mitochondrial function is impaired, which means your insulin release is impaired. So you give rest to the beta cells. That's what I showed in one of the slides. And this is an approach which is very reasonable if, hyperglycemia is a huge burden at that time. What we have seen in practice and the way we do things now is very different. So I tell you what I do, because I'm a great believer in remission of diabetes. So all my new patients, they will be starting on 2 or 3 drug combinations, and I will normalize their A1C. Within 6 months, I will normalize their A1C. I use triple combination. And this I can tell you, we'll publish soon as well, but we have the advantage of actually that we can use GLP-1 analog, SGLT2s. All those drugs are available to where I practice. So I have that. So if I were to treat these people, I will use drugs which are cardiometabolically good and which will normalize the sugars without hypoglycemia. So that's the approach I have taken. We have this approach as well that you use insulin just to really reduce the glycemic burden and let the pancreas recover a bit. You're right, at the time of diagnosis, you lose around 60 or 70% of the beta cells in type 2. In type 1, 50% is gone already when you become abnormal. So then the loss is 4% a year, and this is what we were saying with the conventional approach. If you use that 4% a year will continue because you're not using disease-modifying drugs. Insulin is not a disease-modifying drug. What we say nowadays that, if you are to treat, use disease-modifying drugs early. Okay, so that's, I think, but yes, insulin you can. And the second question is about the renal side. I think the benefit, that data is from UK PDS, and this is not over a short space of time, because as you know, people, when they are diagnosed, their HbA1c is very high. And a lot of it get better as soon as they change their diet. In the old days, we used to give metformin to everyone. But if they have very significant symptoms of hyperosmolality, like they're drinking a lot and they're peeing a lot, in that case, you have to address the symptoms. Because the goal of treatments is addressing the symptoms, control of the disease, and control of complications. This is how it works. So I think the option of insulin is fine. The reduction in A1C and those benefits are not going to be there with what you was trying to say. So this is over a period of time. So when you keep the A1C in the desired range. So what they have seen was that, let's say if it was 8 or 9, and if you reduce by 1% over a substantial period of time, then you see those benefits. Because the changes in the vasculature don't happen instantaneously. They take time. But what is very important is that the underlying pathophysiology at the vascular level is very much hyperglycemia driven. It's insulin resistance driven. Because there is a separate pathway which basically is impaired, which produces the MAP kinase pathway, which produces nitric oxide. So this is why I was saying that control of hyperglycemia is equally important. We mustn't forget that. Because as soon as you get microvascular complications, your macrovascular or your disease of ischemic heart disease risk, you go into the very high risk category, isn't it? Any target organ damage, you go into the very high risk category. Why? Because the underlying defect is basically insulin resistance, which causes endothelial function. So I hope I've answered, but your questions are very elaborate.
Thank you, sir. So we are short of time, so we will not be able to take.
I
So,
will be obliged if I can have.
so you can ask us a short question.
Okay. My name is Dr. Gulasan, and I am fellow endocrinologist. Since morning, we have shown, I think, over concern about hypoglycemia. You know, the GLP-1 analog, they are working as glucose-dependent insulin release, and hypo has not been mentioned with them. Similarly, the glargine, which we have studied from big tech books, they are peakless. There is no risk of hypo with them because they are peakless. And when we listen to the degludec, their pharmacokinetics and the glargine pharmacokinetics and the glargine 300 and 100, what is the specific about? I mean, do they provide the same benefit of MACE regarding the GLP-1 analogs?
Okay, so I think what you're asking is it the combined use of insulin and GLP-1 analogs and whether they confer the same benefit as GLP-1 analogs? Is that correct? I've understood.
Yes, sir, he is asking the same.
Oh, risk of
Yes, sir.
hyperglycemia. I see.
Combination
So risk of
therapy.
hyperglycemia is very insulin dependent, which means that it depends on the insulin fraction. What is very good with GLP-1 analogs, which we have seen in type 2 diabetes, and particularly in those who are using CGM, it basically is an excellent drug for reducing variability. Your variability flattens like this. And when your variability flattens, there is less risk of hypoglycemia. So that's the answer, really. So this is one of the reasons why we use. And the second reason for the combination is that it suppresses glucagon. Because your glucagon remains elevated in type 2 diabetes. Despite insulin, it doesn't suppress it very well. So when you use the combo, the glucagon is suppressed. So you don't get the massive rise of glucose post meal. So I think the combination and the GLP-1 analogs in type 2 diabetes is an excellent addition for a number of reasons. But when you're using insulin therapy and when your beta cell function is lost and people are totally insulin dependent, they have very high variability. Addition of GLP-1 analog flattens this like this. So there is less hypoglycemia and less weight gain.
Thank you, sir. Thank you, sir, for
Thank
your
you very
informative
much.
session. So I would like the chairperson to give their valuable comments about this session.
I think elegant talk and excellent talk by Dr. Safdar Naqvi. He has highlighted the importance and at the right time we have to, at what time we have to start the basal insulin, because the new concept of U300, because it's a compact mass, because when you give the U100 insulin, so the subcutaneous volume of the insulin was large, so it has a different kind of pharmacodynamics. But when you're giving the U300, it's a compact and smaller volume. The pharmacodynamic is totally different and it is very effective. The one advantage is that you have less nocturnal hypoglycemia and you have less hypoglycemia during the phase of titration, because it's a very, very scary thing while you're up titrating the insulin and you will have episode of hypoglycemia. So patient will not be able to take insulin and he will not continue the treatment. And secondly, the fixed dose combination, fixed ratio combination is becoming more popular. We are advocating the simplification of the treatment. So the combination of the basal insulin, which is taking care of the fasting glucose, and the GLP-1, it has unique property. It has a very pronounced effect on the GM motility. So you have better postprandial glycemic control. So with one injection or with one shot, you are gaining the both benefits. You have the better control of the fasting glucose, you have the better control of the postprandial. Excellent talk and very interactive session. And over to Dr. Masood.
I think it was a very important topic that was discussed today. And I think both approaches now is the guidelines are now focusing more to the comorbidities, but and the glucocentric approach is like getting in behind. But I think the balance of both approaches are important, because we cannot ignore microvascular complications that are mostly dependent on the glycemic control. So both aspects are important, and in this Lixi LAN, I think though both of those benefits are together in one medication or in one syringe. So I think the balance of both approaches are important. One should be targeting the comorbidities at the same time, like with the SGLT2 inhibitors, with the GLP-1 analogs, but at the same time we should not ignore the importance of glycemic control as well. I think that's my.
Thank you, sir. So now we are having a break for 10 minutes. Please assemble back after 10 minutes. We are having two important parallel sessions in all A and B after 10 minutes. Thank you. Thank you all.